start the second session. Hello, Tony. I will say just a few words of introduction, and then the floor will be yours. Just a few moments. So, welcome to the second session. And, as you may have heard, the activity of MOX has been, for a long time, interconnected with life sciences. And so there is no surprise that the second speaker is Dr. Antonio Corno, a pediatric surgeon and professor at the Houston Children's Heart Institute of the University of Texas Health and McGovern Medical School. Dr. Corno is a fellow of the Royal College of Surgeons, fellow of the European Board of Thoracic Cardiovascular Surgeons, and fellow of the American College of Cardiology. MOX Group collaborates with Dr. Corno since many years. And we know that besides being a renowned surgeon, Tony, Dr. Corno, is a passionate and generous scientist to whom we owe a lot. So it's my real pleasure to introduce the contribution of Dr. Corno about why cardiac surgeons need mathematicians. Thank you, Tony. The virtual floor is yours.
Thank you so much, Paolo, for these kind words. And I'd like to thank Alfio and the entire team for the invitation to participate to this very important meeting. When Alfio was talking and gave his fascinating talk, he made me scared. I felt guilty because I didn't realize then over all these 20 years of collaboration with his team of mathematicians, I contributed to pollution and climate change. So this motivated me even more to explain why I'm doing this collaboration with the mathematicians. And therefore, the question why the surgeon needs a mathematician is a very simple and straightforward answer. Is because the mathematician help us to solve the problem that we face daily with our patients. Where we have this problem to face in three main areas. The first is the heart conference, which is the place where our colleagues, pediatric cardiologists, are presenting us the cases showing all the investigation. And as you can see on the screen, particularly the 3D reconstruction thanks to mathematical systems, showing us all the malformation of our children we have to operate it on. And here we have to decide which one is the best option for each single child. Then we move to the operating room, and you see is an environment a bit crowded with equipment, instruments, and so forth. This is the heart alarm machine, then is allowing us to work inside the heart. And this is a little heart of a neonate, 3 kilograms, and you can see the size of the heart is like a nutshell if you compare it with the hand of the surgeon. And this heart is already ready for the central part of the operation after being connected with all these tubes and pipes to the heart alarm machine. How can we work inside the heart like a nutshell? Well, we have magnification loops that allow us to see what we are doing. The third and last area is the intensive care unit, which is the room when the child stays after surgery, because that is the most critical period where he needs a lot of support machine, as you can see here, ventilator and so forth, and pumps to infuse the various medication he or she needs immediately after surgery and various monitoring. If you ask where is the child, well, very simple, the child is here, and it's difficult to see because it's very small. This patient was 2.7 kilograms. And to avoid any identification by the law in a children's hospital, I cover the child with this, which is an A4 size piece of paper to avoid any potential identification. But you see here the leg of the little child. So we are having very serious problem and from our decision depends the life or the death of this little patient. That's why 20 years ago, I started to collaborate with Alfio and his team when at that time we were both working in Lausanne. And the collaboration continued even after Alfio and the team moved to Milan. The first collaboration was very funny, and I give you this example because it's important to show how wrong we were to do things before talking to the mathematician. This is an example of one of the frequent operations performed as a palliation in a child. This is the aorta, the big pipe sending the red blood, the rich of oxygen to the body. And this is the pulmonary artery sending the blue blood to get oxygen into the lungs. In many congenital malformations, there is too much blood going to the lungs, and therefore we have to create a narrowing or pulmonary artery bending. This was the conventional one, suturing a tape around, very, very approximative and not allowing any regulation. So when I was in Lausanne, I invented this with the help of an engineer. I helped the design and the production of this design was an adjustable pulmonary artery bending, very sophisticated, implanted after opening the chest around the pulmonary artery and then allowing a telemetry control from distance, allowing us anytime we wanted to narrow or release the degree of narrowing. Of course, before going with this in the patient, we had to do a long-term animal study. And you can see at the piglet, because are the same, then the kids 3 kilo birth, 10 kilo 1 year of age. Here is the scar due to the fact that we needed to open the chest to implant the device. And here you can see all his little brother and sisters in the farm with the device already implanted. But then, when after 6 months, we have explanted the device, we had a surprise. The pulmonary artery wall was absolutely very pliable, elastic. Seen from inside, this was the lumen because the narrowing created by device was not circular, was elliptical or banana shape. And at the microscope, the pulmonary artery was absolutely normal. This didn't happen in our patient with the conventional bending because to create a narrowing, we are shrinking the pulmonary artery, and after 6 months became like a piece of chalk, very unelastic, fibrotic, and this was complicating the reoperation and required multiple reoperation for a progressive enlargement, considering it was implanted in a neonate. At this point, when we already were using this device, I decided to go to Alfio and say, can you help me to discover why this happened in the piglets? Because this can be a complete change of management of our neonates. And Alfio immediately delegated the 2 of junior colleagues. 20 years ago, I can trust you, then they were very junior, Alessandro and Christian, and they started to produce a thesis studying the effect of creating a narrowing on an artery, a pipe that is circular and make it elliptical. Of course, they immediately made a comparison between the relationship cross-sectional area versus the perimeter of the circumference of the artery between the conventional and the ellipsoidal. And then they started to study stuff a bit complicated for me, like the turbulence, wall shear stress, and pressure changes. And I came up with this comparison between the conventional we're doing before and the one we're already doing in the patient at that moment with the implantable device. Of course, I couldn't understand, but they explained to me very simple, Tony, if you see red, it's bad. If you see green and blue, it's good. So I said, that means our device is good. Yes. And they proved this, making a comparison between the same cross-sectional area for the conventional and for the device, narrowing the area to obtain a much smaller cross-sectional area, which is the purpose of the operation. And they showed to me that the circumference obtained with the conventional bending was much, much smaller than the initial circumference, while with our device, the circumference was exactly the same. In few kids also possible to have a growth in the pulmonary artery. So that means this device was respecting the tissue, obtaining the same narrowing, but without any shrink in the arterial wall. And in fact, no one of the patients who had this device required any surgical procedure. So this was something that I observed, but has been explained to me by the mathematician. So after this first study that has been published, as you can see, on an European Journal of Cardiothoracic Surgery, I started to contact the mathematician in advance and ask them before doing anything. Now we move to Newton. It's been quoted already that the previous speaker, and even a surgeon knows the law of gravitation, but that's the problem with the heart lung machine. The heart lung machine is draining the blue blood with low oxygen saturation from the patient and is enriching this blood with oxygen and is pumping back. But of course, you can pump back only what you get. And what you get depends from gravity, from Mr. Newton. And of course, there are various factors to consider: the pressure in the venous system, the differential height between the patient on the operating table and the collector of blood, and all the formula where even a surgeon can see the importance of the length of the tubing and the size of the tubing. Alfio and his team started to do very sophisticated studies, 0D, 1D, 3D. I couldn't follow them at all because I cannot read this formula, having done Latin and Greek and not mathematics at my school. And they were very kind. They continued the study, trying to explain me what were the mechanism of the mathematical approach. And I started to understand only when they made an analogy just to please me and to show me what they were doing with the electrical type of circuit with some fluid dynamics concept that I was very familiar with. At the end, they made very extended simulation, and they come out with suggestion to me. And the suggestion was very simple. We had to change the plumbing for the heart lung machine. And that's what we did. We moved the heart lung machine very close to the bed where there was the neonate or the child on the bed, and we changed the size and the length of the tubing, and you see how straight are these tubing to facilitate the drainage by gravity. And these were the clinical advantages we obtained, again, in pediatric patients to decrease a lot the amount of blood required to prime the circuit, and particularly a substantial reduction in the blood utilization, simply because of the suggestion received by the mathematician, again, presented in a European meeting. This is a very important study that they helped me to do and still helping. That's the drawing of the normal circulation where the left ventricle is pumping the red oxygenated blood to the body. From the body comes back to the right side of the heart after leaving the oxygen, so becomes blue. And here we have another pump, the right ventricle pumping with lower pressure because low resistance, the blue blood through the lungs to get oxygen, and we restart again. So that's the normal circulation with two ventricles, normal heart, left and right. A very large percentage of our kids are born with only one ventricle. And that's a major issue because we have to do 3-4 different stages operation from the neonatal period till the age of 3-4 to create an artificial circulation where the left ventricle or single ventricle available, whatever is right or left, is pumping the blood to the body, comes back, but this time goes through the lungs to get oxygen by gravity because there is no another ventricle available, there is only one. And this, of course, is creating a very peculiar circulation different from the normal, where all the organs exposed to this venous pressure are suffering because they're exposed to a pressure much higher than in a normal situation. I was studying in many ways how to improve our surgical plumbing, and I told the mathematician, well, we can do a different new plumbing in pigs because we have access to pig as experimental material, and we try a new plumbing. No, wait a second, Tony, that's not the way to do, they told me. You cannot go directly to the pig and do your experimentation. You have to start with a MOX circuit. And I say, what is a MOX circuit? So they explained to me, and they made a drawing of a MOX circuit mimicking that Fontan circulation where there is only one pump. And they created, with water, of course, this MOX circuit, and they told me you should use something like inflatable cuff, the one used to measure the pressure, to determine an intermittent external compression to see if you can increase and facilitate the flow through your plumbing. And then, of course, they study from mathematical and computational fluid dynamic point of view how, where, and how long to apply this compression. Of course, they came up with their own mathematical and fluid dynamic graphic, and this is the result of how much, how long, with what kind of pressure you have to do in intermittent compression. Then you told me, Tony, you have to add the valve in the circuit. And again, this has been published in one of our cardiac surgery journal. Then everything started with the iHeart, which is a dream for any cardiac surgeon to have a Game Boy where you can mimic absolutely normal heart, and then in the future and even now start to add congenital defect and see what are the changes and how to pick up the best option. But in the same time, I move where I'm talking to you now, which is Houston, Texas. And now this is a surprise for Alfio and his junior co-worker. This is the way I bothered them in the last few weeks. Starting from Leonardo da Vinci, who 5 centuries ago made the drawing of the aortic valve, one of the 4 valves of the heart. And if you notice, the 3 leaflet opening and closing are not symmetrical. So Leonardo, 5 centuries ago, as usually, have seen very far away. He made the drawing of the valve, noting very well, then were asymmetrical. They are not like the logo of the Mercedes-Benz. This is his drawing, and since he was a genius, he discovered with the tools available to him that the leaflets are opening because of the difference of pressure, and they are closing because the reverse difference of pressure, not only, but because of the anatomical configuration of the aortic valve, there are vortices created, and the vortices are helping the closure of the leaflet, as for his drawing, then has been copied 5 centuries afterwards with the drawing by the mathematician based on the result of the cardiac magnetic resonance imaging. So he was 5 centuries ahead. And now, of course, my curiosity for the children with congenital defect is why the 3 leaflets are asymmetrical. God or Mother Nature, according with your beliefs, doesn't play dice, as Einstein said. It has to be a reason why they are asymmetrical. So we started this study, and it's ongoing now with the support of a mathematician. We have already measured 200 kids before surgery. The leaflet, as suggested by the mathematician, the length and then the distance between the 2 attachments is called intercommissural distance. And we performed a measurement of all the 3 leaflets in 200 kids. The day before surgery, that means with transthoracic echocardiography, which is the probe of the ultrasound on the chest, and the day of surgery with the transesophageal echocardiography, which is the probe is inside the esophagus, the pipe, then is immediately behind the heart to have more precise measurement. And of course, we didn't know how to calculate the area, but with these 2 elements, we gave the formula to the junior mathematician of Alfio team, and they gave us the formula, and now we have 200 kids with all the areas, length, and large calculated, and we proved that Leonardo, of course, was right. 5 centuries ago, they are asymmetric, and we are studying, I'm bothering all the mathematicians every single day to understand why the right and left have different sizes and particularly different shapes. Is this correlated with the normal or abnormal distribution of the coronary arteries? This is what is intriguing us in these days. This is my last slide, and is the take-home message. The heart is the most efficient pump, far superior to any pump produced by human beings, because of the output versus the space occupation and versus the energy utilization. Is one organ, but with 2 pumps, right and left ventricle, except the poor kids are born with only one. In addition, the heart has the capability to adjust to the needs, and from situation at rest or effort when you run to catch a bus to increase the output 5 times. The question for me at this point is very easy. How can we surgeons improve the heart function without the mathematician? Thank you very much for your attention.
Thank you very much, Dr. Corno, Tony, for this beautiful lecture and this also, let's say, maybe suggestions for the future. Any comments or any questions from the audience here or online? In the meantime, I start with one. Do you hear me, Tony, right?
Yeah, very well.
Okay, okay. In the, let's say, you did also an overview of the collaboration between you and your group and MOX over many years. And of course, the slide that you started about the time in Lausanne used, let's say, some, let's say now mature tools for simulation like CFD. My question is about your vision about how the new tools that the let's say scientific computing community uses, like machine learning, like database models, are pervading your area and the medicine in general. Can you, let's say, comment about that?
Great. First of all, I quoted all the previous studies because I didn't want to ruin all your presentation, and I'm sure you have available in the next few hours about iHeart. Of course, we have plenty of publication coming as a result of the studies done in the 5 years process of the grant for iHeart. And this is, in my opinion, the best tool that you can make available to the physician for the next 20 years at least, because as simple as that, for the mathematician, as the perspective presented by the surgeon, Alfio and his team has developed this model, and is almost finished, of a normal heart, then is accessible to a computer, but is truly functioning as a normal heart. It's not only the graphical representation of the heart moving. There is everything behind it. This heart has all the elements of the normal anatomy, the normal histology, which is the microscopic anatomy, the electricity, because our heart has a spontaneous electrical activity. Our heart is beating even if we think something else, even if we sleep. It keeps going for 78 years, hopefully. And then there is the perfusion of the coronary arteries, the metabolism, that means the utilization of the various electrolytes, sodium, potassium, calcium, magnesium, and so forth. The function, how this model on computer can adapt to the change of the heart rate, blood pressure, and so forth. So I nicknamed this as the best Game Boy you can give to the surgeon. And my dream started 20 years ago with Alfio was to develop a model like this, so the surgeon and the cardiologist can enter in this model any of the congenital or acquired disease, like a hole between the two chambers, the absence of a ventricle for us, for the adult cardiologist, cardiosurgeon, a disease of the coronary arteries or due to high blood pressure because of the wrong diet and so forth. And once we have the defect or the disease introduced in the Game Boy, then we can evaluate if the surgical approaches we have available are good, are the best one, or if and what we have to change to improve our outcome. Of course, the evaluation is done by us very empirical because we are artisan, we are not scientists. So we can tell you if the patient is doing well or less well according with our clinical sign. But we have, thank God, the mathematician, and they can tell us in a quantitative way which one of our surgical options is the best. And this will be impossible without this. If you then introduce the artificial intelligence and so forth, you can have a better measurement of our intervention on this Game Boy. But I think this is already the preliminary step to move forward. That's my opinion.
Thank you very much, Tony. And you said, I mean, the IART group has another 20 years to go on. Let's take it as a wish for all of us. And so with that, I will thank Tony again for being with us today.
Thank you very much to all of you. And I wish you a very good continuation of the meeting, because I have to leave you since I have to go to work now. Thank you so much. Bye.